Good morning, everybody, and welcome to Friday Chalk Talk. My name is Martin, and I will be your moderator today. And it's a personal honor of mine to introduce to you the person who probably had the most influence in me entering into the field of palliative medicine. Dr. Ann Broderick, she gave me a chance to be a fellow in her program, and this was in the days before there even was a match. And so I'm grateful to you, Ann, that you helped me to find my tribe. And Ann is now the director of palliative care at the VA in Iowa City. And she's going to be talking with us today about hospice and palliative care unique to veterans. And one more thing before we start. So this past week, I was looking through a notebook of quotes that I had saved from fellowship from Ann and some of my other mentors. And I wanted to share a quote from Ann. And this quote speaks to how palliative care can help really set the tone and preserve hope, especially for this particular clinic patient when she was waiting to see the result of her MRI and whether or not she had progression of her cancer. So, you are not your MRI. It does not erase all that you have accomplished. You cannot possibly get bad news today because you are great, no matter what your MRI says. And so, Ann.
Wow. I said that?
You did. So, Ann, thank you so much and welcome. And I will hand the floor over to you.
All right. So I'm, and Martin, we're seeing my slideshow, right? Not your disclosure. Okay. Well, thank you, Martin. It's really a pleasure to do this and a pleasure to be part of Chalk Talk. And I regret that this was not a collective effort with my VA colleagues in Milwaukee. We just never got together, but I'm hoping that this is the beginning of a collaboration. Really, when you meet one VA, you meet one VA. So every VA has a different personality. And as we know, every hospice has a personality. So we're used to that. I started in this field in the 90s, being a hospice medical director, also worked at the University of Iowa as both a program director and a director of the palliative care program. I came to the VA with a sense of, I have one more adventure in me. I am combining working at the VA with a volunteer position with Pallium India. So really I have dual adventures going on right now. So what I'd like to do is share what I learned. I trained like many of us at a VA, and I'd like to share what I learned when I came to the VA. So quickly, I'd like to make sure that at the end of this, you understand concurrent care hospice, because this exists for veterans. Understand what monumental work the VA has done with their national leadership in a goals of care initiative called the LifeSustaining Treatment Note. And then finally understanding how a veteran's experience in the military might shape the end of his or her life. If I make mistakes with pronouns in the next talk, I apologize. By far and away, most veterans that we're seeing in palliative care are men, but we do have both women and transgender people. Like a good palliative care physician, I feel like I need to start with a veteran. This, of course, is a stock photo for us. Jim identifies himself as a grandfather, a husband, and like every veteran, I exaggerate, he likes to fish. But he also shares heart-wrenching stories when you remember to sit down and listen and ask, what do I need to know about your combat to take good care of you? This man, not this man, but the latest veteran shared that his job in Vietnam was to make sure that every body bag had the appropriate number of parts of a body. Didn't matter if it was actually the same skin color. The person the bag needed to have 2 arms and 2 legs. He said, that's what you need to know about what I'm carrying for all this time. Diagnosed and treated PTSD for his entire work life. And what I hear from wives almost always is that they've learned to adjust to PTSD. We're seeing a lot of Vietnam War veterans in a variety of ways, sometimes knowing that they never can wake their husband. They need to figure out ways to waken them without actually touching them. If they don't want to have a physical response to being awoken. Important for all of us, and I didn't know this, so I'm sharing it with people who may not know it either. It is the largest medical education institution in the country. And put in perspective that 60% of residents in the United States are trained at some point in the VA system. And that 60% of residents includes pediatrics. So it is a large percentage of people who treat adults are trained in a VA. It's also a very large research institution. And really, Kaiser on steroids. It is the largest integrated healthcare system in the country. And the numbers are all there. We also have a variety of other, there are clinics that surround every VA hospital, but now there is a home-based primary care program, which while they don't call it palliative care, it is for people who can no longer get into the clinic, and a team goes to their home, a full interdisciplinary team. Therapist, social worker, and nurses, physicians. No chaplains are not part of that team. Here's the other thing that I did not realize until I came here 4 years ago, which is that the VA is a safety net hospital, definitely for rural America, but also for urban veterans. Eligibility is based on having an injury or a medical condition that either occurred in service or you were found eligible afterwards. So Agent Orange is a big exposure that was in Vietnam, but not only in Vietnam. Some Korean War veterans also had Agent Orange exposure. What, if you could just hop on the chat and tell us what condition you know to be related to Agent Orange. I'm just going to sort of encourage you to do that while I keep talking. So, but in addition to eligibility based on service connection, you can also be eligible, as my uncle is, based on income. But copays could be required then. So Martin just said cancer is good for you. That's a good one. I just want to, I have to look at it because it is Hodgkin's disease, multiple myeloma, lung cancer, non-Hodgkin's lymphoma, prostate cancer, all respiratory cancers, Parkinson's disease, diabetes, ischemic heart disease, B-cell leukemias. Yeah, thank you, Jerry. I agree that he wasn't very specific. The key is, are you asking every 70-year-old in your civilian clinic if they were veterans? Because it might be important that they know that they're eligible for certain benefits through the VA, even if they don't get all their care here. So I wanted to just quickly say what was most surprising when I came here. First is the transparency. If we do something incorrect, a report can be made to any congressperson or senator, and we get a note from the senator's office saying, please look into this and get me back a report so that I can talk to my constituent. Tremendous transparency. Also, nursing home care is free for hospice patients. It has to be a contract nursing home. It's not every nursing home. Skilled nursing home care does not require that a veteran be homebound, a huge benefit to veterans. Surrogate decision makers are different. And in contrast to the civilian world, if there's no family, a friend can act as the surrogate. In fact, it's in the lineup of alternate surrogates. CPR discussions I have found moving from the civilian to the VA are very different as patients, as veterans have, especially combat veterans that have faced death before. This is the first healthcare system that I have seen walk the walk and pay for caregiver support, and patients' families can have a caregiver paid for under certain circumstances. And probably the most gut-wrenching moment is in contrast to my civilian hospital experience where doors are closed when a body is taken to the morgue. The doors are open when a veteran's body is taken to the morgue, and all the veteran employees are called to that hallway to give a final salute. Those of us who are not veterans also can participate, and you can hear the frog in my voice because it is among the most moving moments for both the people who have cared for that veteran and the family. We did telehealth before the pandemic, in part because veterans are often or can be 2 and 3 hours away from our hospital, so bringing them in. And the VA supplies them with an iPad to make this happen. In heart failure, a veteran can have telehealth that monitors weight, oxygen saturations, blood pressure on a daily basis, so that we can intervene in heart failure on the same day as a weight gain has been registered. A phenomenal service, and we now really use telehealth even in hospice. So the big news when I got here, actually a former fellow told me about this from Omaha that was actively doing concurrent care hospice. So the VA allows a veteran who qualifies for hospice to be admitted to hospice even when they're still getting disease-directed therapy. So this means a patient who is getting what oncologists call palliative chemotherapy can also get hospice at the same time. We worked hard early on to build relationships with hospice so that they understood that the VA was a different payer than Medicare. The requirements are the same. The patient still needs to be incurable and understand that their disease is incurable. We're noticing that our hospice length of stay rates have close to our median length of stay has definitely doubled, but still in the 40 to 50 day range. So what the VA was trying to do with this concurrent care idea was to catch patients. This should look familiar to all of you. This is functional status, and location and time. So we start seeing seriously ill patients, the caregivers start compensating for them, and they start getting admitted to the hospital. They might have a couple of admissions to the hospital and then start getting admitted to the care center for rehab, and then that doesn't even work, and they get admitted to a care center under intermediate care, not skilled. What we're trying to do is pick up veterans when they're still in their homes. Most veterans want to be in their homes at the time of their death. And so we're trying to pick them up earlier, with the risk that maybe they have to be graduated from hospice, but at least we don't miss it. I'm going quickly because I want time for discussion. The VA Life-Sustaining Treatment Initiative was an ethics initiative that was designed to help veterans make their wishes known. There are 4 important components of this note, and this is now required for at least our hospital. We're making it required for anybody who's admitted, or if somebody has a score, which the VA has on every veteran, that suggests that admission is imminent or a death is imminent. So the first is, and I know the palliative care clinicians on the line will recognize that we don't always assess for capacity before we have conversations with patients, but we now need to document the capacity of the patient, of the veteran, to make decisions. The second is, do we have a surrogate who will stand for that patient, either because they've signed paperwork or they are in the hierarchy for federal property? And then what documents are available to help guide us understand what the veteran wants? And then their goals of care. And we use VitalTalk techniques to identify goals of care, what's most meaningful to you, what brings you joy every day, and then document whether they want CPR, whether they want to be intubated, have a feeding tube. And these are durable orders. That is, once it's documented, it is a durable order and does not need to be redone in different locations of the VA system. Now, if a patient is readmitted, we teach the staff and residents to say, I notice that you had a do not intubate, do not resuscitate order in the past. Is this still, are these still your wishes? So this note, quite comprehensive in its scope, is now the standard of care in the VA across the country, with I would say fabulous uptake on the part of the residents at this hospital, in large part because of the uptake of the residency, chief residency leadership. So again, puts the veterans in the driver's seat. Goals and preferences are documented with Decisionality. We have this CAN score that helps us understand if somebody's likely to be admitted or to die. And as I said, these trainings are based on conversations in VitalTalk. So some of you might say, how am I supposed to know how to talk to a Vietnam War veteran as opposed to a Persian Gulf veteran, as opposed to a Korea War veteran? This site is the We Honor Veterans site, is a place where you can go. It's a collaboration between the Department of Veteran Affairs and NHPCO. You can go there and say, what are the issues that I need to understand while taking care of a veteran who is in the Persian Gulf, who is at Camp Lejeune, so based on exposures or based on the time that they were in the military. So I encourage you to look at this. Hospices work on getting from level 1 to level 5. This is not easy. Very high functioning hospice in our community is at 3 right now. It is hard work to show that you are a true veteran partner. But I encourage people who are curious about treating veterans and more about the differences between different combat eras to go to that site. So I always like to end with the patient himself. It's been my experience at the VA as a 60-plus-year-old is very different from my experience as a 20-year-old. I think I'm thrilled to be in a integrated system where our mission is the care of the veteran. And I'm also happy to take care of people who are in a economic place that is different than what I saw in the civilian world. So I think that's, I wanted to make sure that you knew that that there are references about concurrent care and how that's done. I'm ready for questions and comments. I'm hoping that I've left enough time for that, though I see it's 10:05. How did that happen? So there's a question: how do you help patients who have symptoms of PTSD at the end of life? I am not an expert on that. The way I have handled it, and I'll try to get more answers to share with you, is that I acknowledge their service, and I acknowledge the difficult work that they did, and I ask them how do they think its impact, what impact that will have on their end of life, if that's what I'm talking to them about, or their medical care in general. So I have, as many of you know, especially those who are my age, it was not a pretty scene when patients, when veterans came back, when Vietnam War veterans came back. It took a long time for the VA to recognize and treat PTSD. I think that acknowledgement, they say, makes a big difference. And I've been often told over the last 4 years that that I'm the first one who's heard this, including family members. Has any information or research come out of the Million Veteran Program about care? I'm a veteran and I'm part of this study. Please feel free to unmute. I'm going to plead complete ignorance.
This is Andrew Calhoun. Yeah, I know I participated in this research here. I know they created a website. I just want to know if there's any pertinent information. I know over 800,000 veterans have participated in this study. I just want to know if any relevant information about long-term care, anything come out from the analysis of the study.
Yeah, well, thank you, Andrew. I love doing this so I can know other things to learn. I don't know.
And maybe I could ask you a question. I've also noticed that it's been really different to talk to veterans about CPR. And I haven't talked to as many as you have. And so I am worried about stereotyping, but I have seen some patterns. And one of them being veterans telling me that they have sort of been ingrained that they fight until the end, even when it is hopeless, even when they know that they will die, that's part of their background in the trenches, going out fighting. Very difficult to talk with those patients about setting some limits. Is that something that you see, and what else do you see out there?
Yeah, and I think you're absolutely right that we need to be careful of characterizing, but it's one of the reasons I love the Life-Sustaining Treatment Note initiative is that we can identify those factors early. If the warrior narrative is how they want to do end of life, then it's important to identify that early, and what does combat when it comes to cancer or heart failure look like. So really engaging them in what do they want to fight for. So I'm not a big one on the warrior narrative for cancer, but sometimes it comes up. So and I have to say that one time I had to advocate for a patient to die in our ICU. We avoided CPR at the last minute, but it was important. And I said I wasn't going to participate in stereotypes, but he was a Marine, and the Marines tell me that this is a risk factor for them, that they are going to go down. They need to know that they did everything to protect their family. Sometimes if we get to know them early enough, we can have protecting their family looking different than going down, dying in an ICU. I also will just say that veterans as a group, but Vietnam veterans in particular, don't put up with lack of straightforwardness, but most important, they want to see genuine. And often I use very explicit language. I say, if the nurse comes in and finds you deceased, no heartbeat, not breathing, I give them a warning shot before I ask that question, but then they know what I'm talking about. And I ask them explicitly, have I upset you with this question? Oh no, you're the first one that's asked it in a way that I can understand it. So I think it can go both ways, Martin. Sometimes I have a warrior narrative, but sometimes I've seen combat. I shouldn't even be here. My buddies didn't even make it. Be straightforward. So I know I've gone too far.
Right. All right. Well, thank you, Anne. We really appreciate your time.
Oh, yes, thank you. And I love this series. Thank you for keeping it going. Really appreciate everybody.
All right.
Yes, can I say again real quick, Anne, thank you for being here. I know I chatted it, and to you, Marty, and I just want to make clear to the whole group, that wasn't a dig on Marty. That was my own ignorance. I knew there was a broad range of health implications, so that's what I meant by that. So.
But Anne took advantage of the opportunity.
I know. I noticed that.
No. It's all friends here. It's all friends. Yeah. But he was right when he said cancers. That's good. But it's more than that, and it's worth knowing. So, all right,
all right. Have a great weekend, everybody.
Okay.
Thanks.
Yeah, bye-bye.
Bye.